from the vasculature, from the plasma volume, and you're going to start going into shock. Before then, it's going to pretty much be an interstitial problem, and you can replace it slowly. There's no rush here. You replace shock deficits in an hour. You replace hydration deficits in what? A day, 24 hours. These are generalization, meaning there could be specific cases that I treat differently. Why do I treat shock in an hour? Because your heart needs to pump blood, and that's vital, right? PPR. But hydration, you have to do it slowly, because the faster you do it, the more you mess with the other compartments. So for me, the best way to hydrate an animal is to make them drink. To put an nasogastric tube. It's a lot more physiologic than putting an IV and blasting them, right? But if I have to replace plasma or whole blood volume, yeah, then you need an IV. There's no way around that, right? There's 100 bazillion charts like this. Some of them incorporate history only. Some of them incorporate history, physical exams, findings only. And there's a third, and that's this one. And there's a third one that includes BUN and creatinine and specific gravity on top of history and physical exams. The more you incorporate, the higher you get as far as assessing hydration. So let's say Fluffy comes in with a history of vomiting this morning, and he has vomited 3 times, and he comes to you, and you find a normal skin tint, and you find decent moisture in the gums, and you find that it doesn't have any sunken eyes or retracted eyes. What % dehydration would you put Fluffy in? That's not quite right, but if you have 0, 1, 2, 3, 3.7, you can do whatever. You have to commit to something, right? Generally what they say is to put him on 4%. So why is he not showing signs of dehydration? Because it takes time, right? So that's when you want to catch him and treat it. If you have anything at 4 or 5%, if you can stop the symptoms, you can probably treat it through a subcutaneous route. You don't have to go IV. So when we go IV, probably going 5% and above. Okay? How much do you guys want to know about fluid therapy? Are you happy with just this basic concept, or you want to like tackle it and do something with it as far as treating a case? You want the 5-minute version, or you want the, hey, no, I want to be able to treat a patient in shock or a kitty with renal failure? The second one? All right, well, let's treat a patient in shock first. Turn to page 7. That's going to be your, it's like resuscitation endpoints. You don't just give volume in a patient in shock at the 80 ml/kg dose. You don't. That's much, right? You have to titrate to effect, but you have to know what effect is that. For that, you need to have some sort of end goal. And this is a chart that has end goals. These are all parameters that indicate how well your blood flow is happening. So they're called perfusion parameters, okay? Everyone is in this resuscitation endpoints chart? Let's flip this chart, and let's start with the bottom. Clinical indications. You're going to see that there's a high end and a low end. We do high end when we have full losses. So I'm not bleeding internally in as much as I'm bleeding externally. So I can control that, right? Or I have a condition where I cannot compensate for the shock, like if I have Addison's, right? There's no stress response in that animal. But let me put it in a more simple manner. When do we do low-end resuscitation? Well, if I'm bleeding in the brain, you want to be careful, right? If I'm bleeding in the chest, lungs, you want to be careful because these are closed cavities. They can't expand. If I'm not making much urine because I have oliguric renal failure, yeah, don't give me more than needed because I'm gonna basically create edema, right? So there's moments where you have to kind of titrate even tighter, but in general, just look at the high end and let's work with that for the purpose of this discussion. Again, we're going from the bottom up. We're gonna feel the femoral pulse. Everyone can do that, right? What's another pulse that we can feel? That is probably better than the femoral. Dorsopedal. You know where that is? Who doesn't know where that is? Is that like incense or humidity? Is it legal? So dorsopedal would be here, on the medial aspect at the ankle level. Medial aspect, feel it on the greyhound, on your greyhound. Has a great dorsopedal pulse. So why do you need to know that? Because the femoral pulse, right, is a bigger portion of that artery, so you're going to be feeling that until they're very hypotensive, right? But if you grab a more peripheral extremity portion of that artery, then that's going to be more sensitive to more subtle changes. So your dorsopedal, in essence, will tell you, if you lose that pulse, you're probably at systolic 80 or below. If you lose the femoral, you're probably at 60 systolic or below, like almost there. Okay? So I want to give you two areas to feel. Feel it on a normal dog, don't feel it on a hypotensive dog, it's going to be hard. Dorsopedal 80, you lose it at 80 or below, unless you're really well trained at feeling it. And the femoral will be 60 or below. Make sense? And that's what I go by a lot. CRT, capillary refill time, should be 1 to 2 seconds. So if you blanch on the gums, they should come back to pink in 1 to 2 seconds. If they come back in 3, what's happening? Yeah, you have lower blood flow, and that's why it's more sluggish, right? With that, your gum color will change, right? As you have sluggish blood flow, your color will change into this like pale pink or grayish color. So now they go from pink to kind of more pale or more grayish.
So if a patient is going into hyperthermic shock, how quickly does the change in gum color usually occur?
It depends on how fast they're going into shock.
Okay, so for example, a dog was hit by a car yesterday.
Yesterday.
By my house. So I went out to try to help.
Today?
No, yesterday. And he was alive when I was running. By the time I got to him, his gums were completely white.
Yeah.
So I was just confused because it was like instant. So,
Well, it could be that he's bleeding internally massively.
yeah.
Or it could be that he's bleeding internally for sure, but also he has a stress response, right? The sympathetic nervous system gets really increased, and what happens is you constrict the peripheral vessels, right? And so there's no blood flow to the periphery, no blood flow to the GI tract, like this blanking circulation gets, because the body's trying to centralize all the blood into the heart, the lungs, the brain, the vital things. So that's the trick, to recognize that. Because most people will come to me, oh, but he's really anemic. I'm like, how do you know? It could be that he has a sympathetic overdrive. And you can get that, by the way, if someone walks behind you without even bleeding, and you point a gun in their head, they're going to get that, they're going to turn white, right? So it can be a very powerful response. That's why you don't walk around giving epi to people. So the epinephrine will do that. And so at the end, I don't know if it was just blood loss or it was blood loss and the response. So I always look at the gums, I always look at the CRT, I always feel the pulses, okay? Heart rate. A dog that is in shock, that same dog should have had a high heart rate, right? You're trying to circulate blood at a faster pace to make up for the fact that you have less volume to circulate and less cells to provide oxygen. You're probably anemic at that point, right? If you're bleeding. So a normal good response would be a tachycardia. It doesn't mean it's normal, it just means that you have to do something about it. Now cats don't do that, unfortunately. cats become bradycardic. So a cat in shock will have a heart rate less than 140 beats per minute. Assuming the pulses are weak, right? Assuming the CRT is delayed. Assuming the color of the gums are pale pink, okay? They just respond like they want to die faster. Any question? We're gonna bypass central venous pressure for now. Yeah, good question. I think they don't. So what that chart says is dog less than 140, and then cat between 160 to 200. So you have to take it down. That makes sense, guys? So heart rate, dog would correspond to less than 140, and cat would be 160 to 200. Just draw a line there. Line them up. Right, so that's where you want them. You want them at what, 60 to 200. These are end goals. These are end goals. These are our targets. This is like your checklist to say, yes, I got that, I got that, I got that. So you don't start treating blindly. I don't want you guys to treat, oh, it's 80 mils per kg, just give it. It doesn't work like that. It's like, okay, I know I can get up to 80 mils per kg, but I need to get to this point, and if I get to this point, I stop. I don't get more. Because overdoing it is really bad, too. A good question. There's one parameter here that I don't have that should be mentioned, and it's lactate. When you're not delivering a lot of blood flow to your muscles start undergoing anaerobic metabolism, right? And then you develop lactic acidosis. So you can measure that with a point of care testing, like with a drop of blood, just like we check the glucose. And if your lactate is above 2.5, you are building up hyperlactemia. If that corresponds to a patient that got hit by a car and has weak pulses, and the gum color is kind of pale pink and delays your CRT, etc., that hyperlactemia is probably from low blood flow to the big muscle, okay? And that's a cool number because you can correct it, meaning you can do a bolus, and immediately after that bolus is done, you can recheck it. If it's trending down and normalizing, let's say from 7 lactate, then it goes down to 3 with your bolus, you're on the right track. And your pulses should be getting stronger, your CRT should be getting better, your color should be better, etc. So that's an important one to remember. And last but not least, last and least, some criticalists hate blood pressure. They believe that it's the crappiest, most insensitive tool on earth. But I think it's the one that you guys are going to use the most, right? So I'll say this, a normal blood pressure doesn't mean you're not in shock. But a low blood pressure means you're in really bad shape. Your body will do everything in its power to keep a blood pressure. It will increase the heart rate, it will increase the stroke volume, it will retain water through the renin-angiotensin-aldosterone system, it will constrict all the vessels until you're like super pale on your gums to keep a blood pressure. So blood pressure is something we have evolved since we were like real like monkeys, and it stayed with us. But the fact that you have a normal blood pressure, unfortunately, will mask a lot of patients with shock, and then we don't treat them. So that's why it's there, but you have to be very careful with it. And don't spend too much time. A patient is in shock, got hit by a car, you're trying to get a blood pressure, and you see that it takes you more than 5 minutes, abort. No need to. Use the rest of the stuff. Oh, but it's too basic, it's too simple, pulse. Well, you want to do simple and save lives, or you want to do complicated and try to get a number that is pretty much meaningless, right? So the only reason I would do a blood pressure is if I can get it, and then I can titrate my fluid therapy